Hey, good evening, everyone. Let me get the invite out to our special guest. Hey,
Hey Shane,
hey there, how are you?
good. How are you doing today?
Good. Hey, thanks for joining us.
Thank
I
you for
know
having me.
we always have a little practice connection before we do these, and Thayer was just telling me he's in surgery all day. He just got home, so I know it was a busy day. Appreciate you going straight from that, fighting traffic, to sitting down and
I
spending 30 minutes with me here.
thank you. Thank you for having me, and hopefully we'll have some fun for the next whatever 30, 45 minutes.
Yeah, awesome. So we're here with Thayer Alqadoumi. Hope I didn't mispronounce your name.
Nope, you did
Um,
good.
uh, Periodontist in private practice. I want you to introduce yourself. Tell us a little bit more about you. I know that I got to know Thayer through some of the cases that you were posting on Instagram, and then also meeting at some of the national meetings, like the Perio meeting. And when I saw your cases and the amount of attention that they were getting, um, I was super surprised when I found out that you were a resident at the time.
Yep.
That's a true story. I was like, there were so many people asking you for advice on cases and things, and then find out that was still during your residency. So, um, yeah, tell us a little bit more
Sure,
about your background
sure.
yourself.
Awesome. Good evening, everyone, and good morning for whoever is watching us overseas. I don't know if you guys want to wake up that early to watch us, but anyways, thank you, Shane and Osteogenics, for having me and inviting me. My name is Thayer Alqadoumi. I'm a board-certified periodontist. I practice in private practice full-time, and I'm a part-time faculty at Loma Linda Advanced Periodontics Clinics. Um, Originally, I come from Jordan. This is where I was raised up and grew over there and got my first dental degree. Then I moved to the US. I got my second dental degree at Loma Linda University and practiced for a couple of years. And then I decided I love perio. That's what I want to do for the rest of my life. And I did perio at Loma Linda. And this has been the best decision in my life. After marrying my wife, for sure. Uh, I
Well, that
gotta
was a
be
close
careful.
one.
Yeah, I gotta be careful if she's live. If she's live now, I gotta be careful. But yeah, it's been a fun journey. I enjoy it. I love it. This is my passion.
Yeah, awesome. Hey, that's interesting. So I didn't know that you had gotten a dental degree in Jordan before you came to the U.S.
Yep.
So was that always the plan, or was it like, hey, I think I actually want to, like what, like,
So I think the plan developed when I was toward my last 2 years in dental school. I wanted to continue somewhere abroad, right?
yeah,
I started looking up Germany, UK, looked at the US, and then decided, you know what? I think US is going to be the best fit, and pursued that dream, and it worked out.
yeah,
Got into Loma Linda, and so did dentistry one more time, and that's when I felt, okay, I don't like general dentistry. I don't enjoy it. So that's how I went back to school. And it's tough when you go out for a couple of years to go back to school. It's not easy.
yeah,
So it worked out well.
got it. One more question on that, just because I'm curious. Whenever you have to go back to redo dental school, do you have to redo the whole thing, or do you like get to like test out of some part of the curriculum, or how does
Yeah.
that work?
So for us, we redo 2 years. So we're
Okay,
not redoing all the basic
okay,
sciences,
gotcha.
but it's mostly 2 years, whatever is needed to
Okay,
fulfill the
yeah,
requirements by CODA and the American Dental Association.
gotcha. Okay, we'll jump into some clinical stuff. And um, for the audience, and it looks like we got a lot of people join. If you want to ask questions, there's a, at least on my screen in the bottom right hand, there's like a speech bubble that has a question mark in it. You can click there and write your question. Also, you can also probably type in the comments, and if I see it, I'll be sure to ask it. But we'd be happy to answer all of your questions this evening. And in the meantime, I know I've got some questions, and then also, you and I were speaking on Instagram, where I know you're very active. you get a lot of questions.
Mhm.
You were saying, and I think you've got a few of the most commonly asked questions. So we'll try to answer some of those as we go too, since we know
Sure.
that probably if you're getting those commonly, there's more people here in the audience that would also be interested in some of those answers. But let me start off with just simple ridge preservation, then we'll go to like more ridge augmentation, bigger GBR cases. What's your protocol for ridge preservation? And then also, as you're answering that, think about, are you also, how often are you doing immediate implant placement? Are you letting the ridge heal and you come back and graft, or are you doing it at the time of extraction? Like, what's your protocol around extraction and grafting?
Sure. Sure. Okay, so when we talk about socket preservation, first I would like to know what am I doing and what am I preparing for, okay? If I'm preparing the site for doing pontic site development for a future bridge, then I'm using a slowly resorbing biomaterial, a xenograft,
Yeah.
collagen type of bone graft that stays for a long time, maintain the hard and soft tissue. If I'm planning to go back and place implant in 3 to 4 months, or I'm able to place it immediately at the same time, then I'm using allograft. I'm using FDBA. I use whatever, 70-30 corticocancellous or 50-50. It's not a problem.
Yeah.
Most of the time it's 70-30 mix of corticocancellous, and 3 to 4 months. Let's go with the scenario that if I can't place the implant immediately. Now, most of the time, I aim to place an immediate implant, especially in the aesthetic zone. And if I'm able to, I provisionalize. If I need to do connective tissue graft, any soft tissue management that is needed at the time of implant placement, I would want to do it at the same time. Okay. If I can't place the implant immediately for a huge infection that I just couldn't clean it, I can't clean it. I should be able to clean it, but there is no way we can tell that we 100% cleaned it. And you'll see multiple protocols. You go with the drills, round burrs, or whatever. We can't tell exactly if it's a clean bone or not, but we kind of do our due diligence and do the best that we can do. But if there's not enough stability, all these factors, then I'm not going for immediate and I'm waiting. Now, if I wait, and let's say hypothetically, or let's say for other reasons, financially patient is not ready, let's say. We extract, if we have 4 intact walls and the bone, the buccal plate, especially on the premaxilla, the aesthetic zone, I'm going with any collagen membrane. There is no problem with that. We have intact walls, it's not a problem. If I have a buccal deficiency and it's more of a V-shaped deficiency, or the buccal plate is super thin, especially in the premaxilla and the aesthetic zone, again, this is we're talking about if we're not able to go for immediate, I'm using Cytoplast TXT 200, the singles, the dense PTFE. This is my favorite, the best that can attack these cases. If we have a larger deficiency, it's going almost all the way to the apical part, or it's more of a U-shaped buccal deficiency or W-shaped, then I'm using the titanium reinforced dense PTFE. Okay. Now, keep in mind, all of these, we are doing an open healing technique.
Okay.
You don't have to go for primary closure. You don't have to worry about that. Okay. Now, when we look at these membranes, I'm removing them at 4 weeks after I do the alveolar ridge preservation. The question that I get asked very commonly, like, how do you tuck in the membrane? We find difficulties doing that. Okay. Now, let's go to the scenario that we have a slight buccal deficiency. I'm using the TXT 200, the singles, no titanium reinforced. I always tuck in the membrane on the side where the deficiency is. So I create a little pouch on the buccal, a little pouch on the palatal. Let's say the deficiency on the buccal, then I tuck in the membrane on the buccal. Why? Because when you will have better access to see where that crest of the bone is, where that deficiency is, you'll be able to see that you advance the membrane 3 millimeters beyond that point. And when you pack the bone, you're packing the bone against a kind of like a wall that you created. And when you come at the end, you want to flip over the membrane to the palatal side. It's going to be much easier because the distance that you have to travel in the palatal is not much. You're just 3 millimeters away from the gingival margin. So the bone is up there. You have no problems. But think about it the other way around. If you put on the palatal and you try to go to the buccal after you place the bone is going to be all over. You will start trying to tuck in. You can't see, and your membrane may not extend where it needs to extend. In addition to some of that bone particles may go around. Now, let's say we have a larger defect. We flap the area, okay, to debride and clean and get the area completely cleaned. Then I am using the titanium reinforced PTFE, and I'm tucking the palatal side first. So why I'm doing that? Because I want to get my support from the palatal side, because I have the bone there to help me, and I create a little pouch. I place the bone graft, and then when I flip it over, I can see clinically, I have all my sight with me to see that I extended my membrane beyond that defect, okay? And then I close it back. Now, as I mentioned, no primary closure, there's no need. And when I suture, I'm using glycolon if I don't flap. And if I'm flapping, I'm using the cytoplastic PTFE sutures. This is kind of my protocol when we talk about alveolar ridge preservation, keeping in mind that I was not able, for whatever reasons, whether health, whether financial, whether bone stability, implant stability, the multiple factors that may prevent us from going for immediate implant placement.
Okay, so if you have a 5-walled socket, you're using collagen exposed, is what I'm hearing. Why not use the PTFE there? Why? When I think about PTFE is less expensive, you do have to remove it in 4 weeks. What's the rationale for?
There is no problem by doing so. You can use the cytoplast, the PTFE dense membrane. The only reason is I skip another appointment for the patient to come back to move the membrane. That's it.
So you avoid the revisit.
Yeah, exactly. Because usually my protocol is 1 week follow-up and 4 weeks follow-up. Now, at the 1 week, when I see that the sutures are loose, then they have no value to me. I remove them.
Yeah.
But if they are still holding, then I'm removing them at 4 weeks. At the same time, I remove the membrane. Yeah. And some of the questions that I got, do I have to numb the patient to remove the membrane? No. You don't even need to use topical gel, nothing. I just use a perioprobe, get into any of these corners of the socket, gently lift it up, get a comb plier, and lift the whole thing pretty easy. And you will see that the sides that were tucked in, they're white, they're clean. The side that was exposed to oral cavity, you can see the external surface is dirty, and that's good. That tells me that this is a nice border preventing all of these gunk from going down to the socket. And if you flip it, you'll see a nice clean internal surface. And there's a lot of SAM studies that evaluated that and looked at the bacterial load on that membrane.
Yeah. It's funny, we're getting some comments from Eliana Barbosa out of Brazil, who actually did some of the earliest clinical studies on this material. So she's making some comments, and
very helpful comments. Love to see that.
And her research actually was to show that keratinized gingiva increase that you get by purposely leaving these membranes exposed, and we still cite a lot of her results. So welcome, Eliana. I'm glad that you're here. So thanks for joining us.
Yeah.
So okay, we've done ridge preservation, and now let's move on to something a little more challenging, ridge augmentation. So we've got horizontal, we've got vertical. What's your protocol?
So again, same thing. Always you need to know what's your enemy. Okay, you need to speak the language. You need to know what you're fighting, what you're dealing with. If I'm dealing with horizontal, I need to know what am I doing. Is it vertical? Is it a combination of horizontal and vertical? Am I able to place the implant at the same time of the augmentation, or I'm going to come back at 6 months later to place the implant? Now, let's take the scenarios. Let's say I'm able to place the implant and I want to do simultaneous GBR. If my implant is surrounded 360 with bone, but I need to thicken up the buccal plate, then I'm going with a xenograft collagen, and I'm using any collagen membrane or amnion chorion membrane, and I used glycolon sutures as periosseous sutures to stabilize the membrane, okay? And I'm going for primary closure for sure. And I'll talk more about the primary closure and how it's done at the suturing part. Now, if my implant, some of the threads are exposed, then I need to make sure that I'm harvesting some autogenous from the area, and I use micro-os or safe scraper to harvest the autogenous. And I mix it with allograft, and that's going to be the first layer that is facing the implant. And then I mix that with xenograft, because I always would want to still have at least 20 to 30% of my mix, at least in my hands in GBR. I got to have that mix of xenograft in my augmentations, whether I'm doing horizontal, vertical, using BMPs, GEM 21, whatever. I still want to have xenograft. So I mix the xenograft, same thing, collagen membrane, periosseous sutures to stabilize, or you can tack it. Now, let's say the other scenario is that we're not able to place the implant and we're going purely for horizontal augmentation. Then I'm using whether a non-cross-linked membrane, that's what I'm using most of the time, or a cross-linked collagen membrane, and doing more of a sausage technique instead of an urban. I'm very from Loma Linda, so I got to be very much affected by this guy. He's a legend. So I use the same mix of allograft, xenograft, and autogenous. I mix sometimes some growth factors, GEM 21, RH, PDGF. Not necessarily much for the horizontal augmentations, mostly if I have some slight vertical component. And I tack the membranes when possible, and I use the Meisinger tacks.
Okay.
And I love those tacks for one reason, that the connection between the tack and the handle is very hard, very sturdy. So if the patient moves their tongue, if my assistant hit me, or whatever reason, that tack is not falling from the handle. And I like to grab the membrane and stretch it. So I grab it with a tack and I stretch it, put it exactly where I want it to be, and then I tap it in. Okay, so these are one of the beauties that I'm able to do with the Meisinger that I'm not able to do with other type of tack systems. On the lingual side, if I'm not able to tack, which is very difficult, then I'm using the Profix screws. Most of the time, they're self-tapping, no issues. In dense cortical bone, I have to pre-drill for it, just to get the first grab on the bone and then stabilize it. But it's been very helpful. So this is mainly for horizontal tacking, screws. It's more of a sausage technique. Suturing wise, I am using double layer suturing technique. The first thing is the horizontal mattress to reduce the tension on the flap, and I'm using glycolon. I used to use the cytoplast PTFE, and the problem is to come back at 3 to 4 weeks to remove them, it's pain in the neck. It gets a lot of swelling and they get embedded inside the soft tissue. So I started looking, okay, what can I do? Because I don't want to use chromic gut. I want to use something that's going to stay a little bit longer, have more tensile strength until I'm ready for it to go away. And that's how glycolon came in the game. And it's been a game changer. So I use glycolon for that, for the horizontal mattress, and for the crest, whatever you can use. Cytoplast PTFE, that's what I use most of the time. Simple interrupted or continuous interlocking suture. It's not a problem as long as you do eversion for the flap. Same suturing technique is for whatever type of augmentation, whether we're doing horizontal, vertical, or combination. Now the membrane choice, that's where it changes when we get to the vertical or a combination. In addition to sometimes the bone grafting, the biomaterials. The membrane choice, I'm using the titanium reinforced PTFE, the RPM, the perforated one.
Okay.
That's what I'm using most of the time. I get tremendous results. Some of those cases, because I get asked, okay, I get exposures. Like, what do I do, right? Because people, we know that 25 to 30%, the best hands in the world, you still get exposure. It's all about the management. It's all about what you do. I like to baby those. It depends on when the exposure happens, but I like to baby those. Keep the patient on strict follow-up once a week, rinse at home, keep it clean. And the minute that I see, okay, now it's time to jump in, I'll jump in, remove it. I'll still place another collagen or amnion chorion membrane and close it back, let it heal. But to go back to the vertical and horizontal, I'm using that membrane or sometimes titanium mesh. I used to use your gold tie mesh. I forgot what it's called. But I love it. I have really, really good results. But to remove a PTFE membrane, it's much easier than removing a tie mesh and chair time.
I think the
All of
removal is where you appreciate spending the few extra dollars to on the PTFE. All right, I think we've got about 9 minutes left here, and I want to cover a couple of topics. I know you do some interesting things with the sinus.
Yep.
Tell me about sinus elevation. Are you doing crestal? You're doing I'm drawing
the whole window. Yep. So this was my my master research in residency. Okay.
Yeah.
So just to give people a glimpse on what we did, we compared osteotomes to the versadrills, the osteodensification technique, and we wanted to see the incidence of perforation. Okay. And what we looked at, if we have 5 millimeter residual bone, and we want to lift another 5 to place a 10 millimeter implant, how often do we get perforations and when does it happen? Now, just to give everyone in a nutshell, versadrills are amazing. They're a great invention. But people are overusing that in the crestal sinus elevation, because the perforation chance may happen. And the problem is that it might not happen with the drilling, because the drills are doing a great job on the sinus membrane. The problem is that most of the perforations are happening at the time of implant placement. Because if we think about it, if I want to lift, let's say, for a 10 millimeter implant and I have 5 millimeter residual, how much am I lifting?
Yeah.
I'm not lifting 5. I got to lift 7 millimeter, because I need to compensate for that tip of the implant. If it's going to end at the end of that elevation, it's going to perf. In addition to, do we have a way to measure how much we lifted? No. So in our research, we used NovaBone as our particulate, our bone graft. The reason why I use it, because I wanted to remove all the variables out of the equation. I want it to be a very fair assumption between osteotomes and the versadrills. I can tell you the effect and the hydraulic pressure that this NovaBone causes on the sinus is amazing. How it lifts up the sinus and gets you that dome. And I feel and believe that revolutionary changes happened to the crestal sinus elevation compared from where we started in 1994 with Summers technique is attributed to versadrills, part of it, and another part of it is the NovaBone. Okay, because that putty is helping a lot in elevating the sinus. The drills, we can't extend them a lot inside the sinus cavity, so we have limitations on how much we can go in. So the bone, I feel, is what's doing that cushioning effect and giving that elevation. The one thing we noticed, and I would like if any of the audiences get to start looking at their cases, we noticed that the sinus width may play a role. And we found 7 millimeter sinus buccolingual width of the sinus as kind of like a magic number that would be dictating, are we getting more of a wide, flat elevation or more vertical localized? And if it's narrow sinus, we're getting more of a vertical localized and we're getting more perforations. If it's a wide sinus, we're getting more of a flat based. And as you get the NovaBone, you can see that the membrane detaches nicely. Because what we did, we cut the cadaver heads from here below the orbit, and we looked from the top. So it was a human cadaver study. And we can see exactly in video record what was going on and what's happening as you insert the bone, as you insert the drill, and all of that. To answer the doctor, not published yet. It is about to be submitted. Hopefully within the next week or two, we'll submit it for publication.
Awesome.
But I can share if you'd like more info. So that's why I feel that having a cushion that will help, and the sinus width, the wider the sinus, I'll take more risk in going in crestal sinus elevation. So my protocol today, if I have a 5mm implant, I'm still going for a crestal approach. I'm having 8mm implant ready on the side. If I see a perforation, which the beauty of the Verta drills now, you get a nice osteotomy that you can clearly see the sinus membrane. And I see the perforation, then I'm using implant without a bone graft, just the implant. I break the sinus floor, then I use my sinus curettes. I kind of do like the Yamada technique. I try to lift the sinus slightly, and then I let Nova Bone take care of the rest.
Okay. In your research, you were comparing osteotome to the Densa drills from Versa.
Yep.
And you were using Nova Bone in both groups. So, did you find that the Densa burrs had less perforation than the osteotome, or was it not statistically significant, or what was the?
So let me tell you, if you read the research without reading the details about it, you're going to be like, this is crazy, because percentage of perforation was 40%. Now sample size is 10 cadaver heads, okay? It's very hard to get cadaver heads to match the criteria that you're looking for. I have to scan at least 60 or 70 cadaver heads to get to have 10 available. Now, if we look at the perforation, it happened most of the time at the time of implant placement.
Oh, okay, yeah.
So 1 out of 10 perforated with the Versa, 2 out of 10 perforated at the osteotome, 0 out of 10 perforated when we placed the Nova bone. So no perforation ever happened when we placed the bone graft. The only perforation happened as the implant is going in, it's tearing the membrane. Okay?
Yep.
And we've done multiple studies at Loma Linda cadaver studies looking at that, looking at not tapered implant, more a parallel implant, to see is that taper of the implant going to cause that problem. We've had even more extensive studies that had 4mm residual bone. Still, the crestal sinus elevation is very tricky. Yeah. Case selection, material selection is very important, in my humble opinion. That's why, yes, I see beautiful cases, 2mm residual bone, they're doing crestal sinus elevation. But out of 10 cases, how many can we do that?
What if you just put in more Nova bone? Would that not solve the
that could solve the problem? I have no problem. But I'm more concerned if I have a 2mm residual bone, we're doing a crestal sinus elevation, we're doing tons of Nova bone, and then placing the implant at the same time. That's when I'm more concerned, that I want to know. I want to take baby steps, wait, let the Nova bone turn over, because I'm seeing really nice turnover at 6 months, and then go back and place your implant.
Okay, awesome. We're close to out of time, but I want to ask one other question, one other topic that I try to always ask our guests, just because it's something it's an area of research. It's an area of research and treatment that's evolving very quickly right now, and I find it very intriguing, is periimplantitis.
Yep.
So I think the answer I hear most often is if half the implant or more is still in native bone, then we're leaving it. If not, we're extracting. Then you also hear if it's my implant, we're saving it. If
that's the answer that you hear the most.
Yeah.
That's what you hear the most.
That's probably the most honest answer. Yep. But I think, so yeah, what are you doing to treat the implant surface? When do you save? What do you do to treat the implant surface? And then are you regenerating? And if so, what's that protocol?
Okay. So my protocol changed a year ago when I started using lasers. Okay. So I use the Nd:YAG laser. And nowadays, what I do, if I have 50% or more of the implant is in bone, and I look at multiple factors, look at the patient health, look at if they're diabetic, if they're smokers. So there are multiple factors that I look at in the game. But it is very imperative that we get the patient involved in what we're doing. They need to know that you walked in with this problem and we're trying to help you. I understand our, sometimes if it's my implant, I'll treat it differently than if it's somebody else. But at the end, this is a patient. And we need to try to do the best to the benefit of that patient because they spend a lot of money on that implant. If I tell them, okay, let's start doing some bone grafting, all of these procedures, they may run away that they already spent a lot of money. So nowadays what I do the laser, I give it 6 months to a year. First, by doing so, I'm improving hopefully the soft tissue quality. It's more healthy. I'm reinforcing the patient oral hygiene because I need to make sure that the patient is doing their due diligence with the hygiene. If there is any pending problems, if there's diabetes, I'm making sure that they get that controlled, get their A1C. Smoking, we work on smoking cessation, even though it's very hard to have patients stop smoking, but I'm working on these things. And then after 6 months to a year, I'm doing my evaluation. If I see we're regenerating and we have some bone coming back, then we're good. I'm keeping the patient on a strict 3 months maintenance protocol. If the defect is gone, hallelujah, we're good. Now, if the defect is not gone, this is where I'm gonna decide and go back again to see, am I able to regenerate, go with bone grafting, membrane, do I have the chance, or I'm raising a flap, just doing implantoplasty, leave that, do some soft tissue augmentation, and let it be more like a, what do you call it? Like a transmucosal attachment with the soft tissue for the implant surface. So this is basically what I'm doing. If I have a graftable defect, I can graft. I'm grafting it. How do I clean it? There's multiple people we can ask, and those are the experts in that field. Alberto Monge, George Kotsakis, all these people. That's what they do all day long. They research this topic. And I clean it with cotton pellet and just saline. Try as much as I can to debride the implant surface. Now, at some point, I was like using stainless steel. I don't care. I just want to clean the implant surface. I know that bacteria is more harmful than being the implant surface destroyed. So we've got multiple enemies that we need to think about. Okay, which enemy do I want? Yeah. But this is basically what I'm doing in conjunction with having the patient be very involved, very aware. It's very easy to remove and start all over. It's harder to try to keep, but we need to make sure that the patient is willing to go through that.
Awesome. Well, hey, time flies. We're 35 minutes in. I appreciate your time, especially after a full day of surgery and getting home to the family and spending 30 minutes with me. I mean, your cases are awesome. I would encourage everyone to go follow you on Instagram, but my guess is that 90% of the people who have joined us today are already following you. But if not, I'm sure that they've followed. I enjoy the cases, the photography, the all of it. So appreciate your time, respect your work a lot.
Thank you.
And look forward to seeing you next. Will I see you in Austin at the Perio meeting?
Yep, we'll be there.
Awesome. Well, I'll see you then. Awesome. Thanks, there. Have a great night, and thanks again for your time. Bye, everyone. Thanks for joining us.
Thank you.
Good night.